Hello, my name is Charlie VR, and I'm in your abnormal psychology course. And the disorder which was assigned to me was acute stress disorder. So we're going to be defining two terms: acute stress disorder and post-traumatic stress disorder. So we're going to be defining acute stress disorder, a traumatic event or more which can lead to an intensive, unpleasant, and dysfunctional reaction, which may last from a day to a month. If longer, it can be a diagnosis of PTSD. Post traumatic stress disorder is an event in which a person has many flashbacks of the traumatic event or witnesses a traumatic event, which can last a month to many years when triggers of the traumatic event are still being present. With this being said, acute stress disorder is, I want to say, the more easier way of explaining it is probably going to be the little brother of post traumatic stress disorder. If people who are diagnosed with acute stress disorder and then they later on tend to have post traumatic stress disorder due to that specific event or any other one. Now we're going to go over to the DSM-5 diagnostic criteria. We're going to start with the letter A, which is exposure to actual or threatened death, serious injury, or sexual violence in one or more of the following ways: experience a traumatic event, experience a traumatic event in first hand or second hand, or the event occurred to a close family member or a close friend, experiencing traumatic events rapidly. We're going to go over B, which is presence of nine symptoms. And this category is going to be four different categories and within one. Basically, the first one is intrusive, involuntary, recurrent, intrusive memory of the traumatic event, recurrent dreams of the traumatic event or related to the event, dissociative reactions like if the event was occurring again. Now, we're gonna keep going with dissociative symptoms. Basically, what this is an altered sense of reality of one surrounding or oneself, such as seeing yourself from another perspective. Inability to remember an important aspect of the traumatic event, not due to a head injury, but more of a dissociative amnesia. Now we're gonna go over the third one, which is avoidance symptoms. Some of the avoidance symptoms can tend to be like avoiding disturbing memories, avoiding to like any external reminders such as places, people, specific conversations, activities, and objects, and even situations which they can tend to remind you of the traumatic event. Now we're going to go over arousal symptoms. Arousal symptoms are basic hypervigilance problems with like concentration, exaggerated startles, responses such as flinching too much when someone's around you or when you hear a tire screech, or maybe even like you hear a loud bang. Another one is sleep disturbances. Is basically you won't have enough sleep later in the night, or you can't really go to sleep early. You tend to go to sleep late. And also something else is irritable behaviors. Like you're always irritated for everything, for anything that happens. You're always irritated, and sometimes it can lead to anger burst. Now we're gonna be going over C, which is duration. The acute stress disorder is potentially going to last 3 days, from 3 days to 1 month of the traumatic event, which tends to happen immediately after the event occurs. Now we're going to go over D, which is distress. It causes dysfunction in social, occupational, and even other important areas of functioning. E is going to be disturbance. There is no effect and caused by a psychological effect of a substance or a medical condition. With that being said, we're going to move on to prevalence. It's going to be 20% of the 20% to 50% tend to have an acute stress disorder with experiencing an interpersonal traumatic event. With this being is you either went through the traumatic event yourself, and then acute stress disorder tends to appear in less than 20% when not experiencing an interpersonal traumatic event. When not experiencing an interpersonal traumatic event basically means that you received the traumatic event secondhand, such as when you witness a horrific car accident or a horrific institutional accident. Females are at a greater risk for acute stress disorder. I was able to do this research on my own. I found it the most interesting, and I found it from Mayo Clinic. There's going to be different diagnoses when clients or patients are being diagnosed for acute stress disorder. Some of the overlapping ones are going to be adjustment disorder, panic disorder, dissociative disorder, post traumatic stress disorder, obsessive compulsive disorder, and psychotic disorders, and traumatic brain injuries. Now we're going to move on to the treatments for ASD. One of the treatments is cognitive behavioral therapy, which works the most effective. A form of therapy which can help those who have been diagnosed with acute stress disorder. A little more in depth is you tend to work with psychiatrists and you work with mental health counselors in a structured way. Basically, what this means is you're attending sessions. It can be 6 to 10, and you're going over how negative thoughts and negative thinking can change the views of the disorder that you have, or it can literally change the way you look at the disorder, and you may see it as not a very deficient way, but it can also be that you start thinking more clearly of the disorder and can finally get over the disorder or the get over the traumatic event. The second treatment is gonna be antidepressant treatments. Basically, they're drugs that are prescribed to you. One of those drugs can be clinical Zepam and benzodiazepines. These are all antidepressants. They let you have a more greater, happier life when you're on the medication, but when you're off of it, it can also lead to something else, such as addiction to these antidepressants. That's why a lot of people don't tend to take the antidepressants, and they usually go for the cognitive behavioral therapy. This is the end of my presentation. If I think for everyone who's listening, have a good one, okay?